Hello, everyone. Happy Tuesday. We are very excited to have you here today. Welcome to Access Bridge, addressing today's crisis in reproductive health care from the ED. We are very proud that there are going to be attendees of this webinar today from over half of the states in America. There were about 28 different states represented in the registration list last I checked. So while we were all getting logged on here, I would love for folks to tell us in the chat where you are joining from and your name, and we will get started in just about a minute. Welcome again. We are very excited to have you along on the adventure of expanding Bridge and what Bridge can mean to patients presenting to the emergency department. So Bridge is a program of the Public Health Institute. Our mission is to bridge emergency care and community health to create an integrated system that improves health and equity. This might be new to you. This is a new way of thinking about the Bridge organization that has been live only this year in 2023. So again, thank you for your role in helping us create a new way for the emergency department to serve patients who are presenting, who maybe historically have been marginalized in other settings. I am so delighted today to be joined by three dedicated and passionate clinicians who have stepped up to become leaders in the work of expanding the emergency department to meet the safety net needs of the reproductive health access challenges that are faced today. I would like to begin with some very quick introductions, beginning with Dr. Kelly Pfeiffer.
Good afternoon, everybody. I'm Kelly Pfeiffer. I'm a family doctor. I've been working in reproductive healthcare for around 25 years at a variety of clinics in multiple states. And I've also held roles at the state of California and the California Healthcare Foundation, where I worked with the Bridge program in the work on addiction. Thank you.
Dr. Rebecca Trotsky.
Good morning, everybody. My name is Rebecca Trotsky. I'm a family medicine doctor in Los Angeles, and I've had the honor and privilege of working very closely with our large ERs in our county, serving a public safety net and making sure that we can do as much public good as we possibly can from our little vantage points. So I look forward to working with you guys.
And Dr. Rochelle Jagdeo. Looks like you already have some fans in the chat, Rochelle.
Oh, no. Good afternoon. I'm Rochelle Jagdeo. I'm an emergency room physician. I work in rural California in Placerville, as well as Truckee. I am someone who values health equity and wanting to provide healthcare for everybody, despite their ability to pay, and passionate about women's reproductive health.
And my name is Elizabeth Keating. I am the clinical program director of the Bridge organization and the project director for Access Bridge. Been working on Bridge in the substance use disorder landscape for nearly 5 years, and I'm very excited to be expanding our reach into the reproductive health space, as it's one that is very personally and professionally important to me. So Kelly, tell us a little bit about what Access Bridge is. What are we trying to do here?
Well, we know that emergency care is the only healthcare that's guaranteed 24/7, no matter whether you can pay or not. And if we were in a different healthcare environment where everyone had their own primary care provider, where everyone had access to affordable birth control, where everyone had access to all of their social needs being met, we wouldn't see the ER as a social safety net. But that's the world we live in. And so even though there have been conversations in the years about trying to move low acuity visits out of the ER, we know that for many of the regions that we want to work most closely with, the place to go if you have a need is the ER. That's the only source of care for many of the people that we want to serve. So our vision of where we want to be is that the emergency department is one of the critical parts of the safety net for people who have a healthcare emergency, a pregnancy emergency, and for those who don't have any other source of contraception access.
So you may have joined us today thinking, wait, I thought Bridge was only about substance use disorder. I've engaged with them about buprenorphine and about navigating patients who are using fentanyl. You are right, and we have more exciting news to unveil. So Access Bridge is a new program under the Bridge umbrella. Our flagship program is still California Bridge, which has worked to scale access to buprenorphine treatment combined with warm handoff to substance use navigation from just about 8 hospitals to nearly 300 hospitals in California in just about 4 years. So as a result of this work, we have learned a lot about culture change in the emergency setting. We have also built relationships with hundreds of hospitals in nearly every state in the country. We are considered the standard of care by the leading emergency medicine organizations in America. And we also have a lot of relationships with both staffing groups that staff physicians and other clinical roles, and also with many state agencies that administer Medicaid. So we have set ourselves up to be in a great place to have conversations about the healthcare safety net and how to make social medicine accessible and realistic from the emergency setting. So if you are joining this webinar, we imagine you are interested in pregnant patients. So while the focus of today's webinar is going to be about access to contraception and treatment of common pregnancy emergencies from the ED setting, you also might be interested in learning about the resources that we have for pregnant patients who do have substance use disorder. We have a simple algorithm for treating patients who are pregnant and who are using opioids. And we also recently did a full 1-hour webinar that does have CME attached to it about treating pregnant patients with buprenorphine. So if you are somebody who is interested in pregnant patients presenting to the ED setting, both in general and who are using substances, you might choose to check out those resources after the webinar. But today we are here to talk about Access Bridge, which is specifically about patients presenting to the ED with common pregnancy emergencies and patients presenting to the ED who may have no other source of healthcare to receive preventive healthcare in the reproductive health space. So we know that 1 in 3 Americans do not have access to an appointment with a primary care provider or an OB-GYN so that they can access contraception. We know that nearly half of the states in America have outright banned or are in the process of trying to ban or restrict abortion. And we know that these policies have a deeply disparate impact on patients of color. Patients of color, specifically Black patients in America, face higher rates of maternal mortality and more than double the rate of unintended pregnancies compared to nearly every other racial category. So this is a social justice issue. This is a racial equity issue. And we know that no matter what you think about whether the ED is the exactly perfect right setting for this care, this is where these patients are presenting. The ED is the only source of healthcare for many of the patients who are made most vulnerable by the healthcare system as it stands. And recent data shows that visits to the ED related to pregnancy, childbirth, and other postpartum challenges were actually the 11th most common reason for ED visits. So the patients are coming. They are coming into the ED in every state in the country. The good news is that early pregnancy loss can be managed in the ED setting. So Kelly, do you want to tell us a little bit about what we know about how it's managed and what the hope is?
Great. I mean, there's so much about this that feels similar to the work that we did in addiction, because there's just not enough training for people, physicians, clinicians working in the emergency department on reproductive health care, yet folks are coming to the ED anyway. So it felt very similar to when people said, well, I wasn't trained in addiction. How am I supposed to manage buprenorphine? The program made it very easy to overcome that barrier and to be someone who could easily treat people with buprenorphine. And we're aiming to do the same thing with early pregnancy loss, which includes miscarriage and people who have pregnancies that are not viable. These account for almost 1 million visits in the ED already. So as Elizabeth said, people are coming. Black and Latino women are overrepresented in these visits of people not getting a normal source of, like say, other source of care, like OB-GYN or a family doc or a midwife. And people who presented to the ED were less likely to receive active management, which is considered the standard of care if someone is having a lot of discomfort with bleeding or pain, either getting medications, which are highly effective, or getting procedure care. Most people go into the ER, get told if you're not dying, just wait it out, and that 28% of these end up needing later procedures after going through potentially days or weeks of suffering. And we also know that despite robust evidence that mifepristone and misoprostol work for miscarriage, it's only used 2% of the time in the treatment of EPL. And so that's what our goal is, to just make it easier for emergency departments to use medications that work in the treatment of miscarriage, and to give clinicians the skills so that it is just as easy to do as any other part of your work. We also want to build skills in how to make the emergency care of miscarriage less traumatizing for the person going through it. It doesn't take a lot of time. You don't have to have a degree in counseling, but just simple words like, this is not your fault. And then simple strategies to help the patient share decision-making about treatment options can be really life-changing for the people under your care.
Dr. Jagdeo, you are an emergency department physician. What role can they play here? Why is this not a crazy idea?
It's not crazy. We're actually already doing it because we're open 24 hours. We take anybody's insurance or lack of insurance. We never turn patients away. And we're kind of the only doc now that's trained to treat anybody, regardless of their age, at any time. And so we treat all types of patients. And most importantly, we're often seeing patients in their time of crisis and their time of need. I take pride in being the safety net for my community. And not only do I provide emergency care for trauma patients or when you're having a heart attack, but often I am the only point of care and can be their access to primary care. So we are just ripe with opportunity to kind of take this on, own it, and manage these types of patients.
So we at the Bridge organization have learned a lot about creating both cultural and clinical change in the emergency setting through our work on opioid use disorder. Dr. Pfeiffer, how are we applying these lessons here?
You know, Atul Gawande wrote this great book about how change happens in medicine and why ether, which was introduced in the mid-1800s, spread like wildfire around the world, and hand washing for antisepsis took generations. And what the Bridge program has gotten really good is to make culture change a lot more like ether and less like hand washing. In other words, how do you make something easy to use to solve problems that you, the clinicians, are experiencing in the ED? So it's second nature to adapt these. And a year later, after the program starts, or after borrowing our algorithms, you say, this wasn't so hard, why did I make a fuss about it? And that's how we found with buprenorphine, just our goals are to have easy to read protocols, easy to read algorithms, easy to implement, designed by specialists. So we ran all of our algorithms, of course, by OB-GYNs and family physicians who are in the field, but make it so they work in the ED, since we know that speed and efficiency is critical for adoption. We also know that sometimes culture change is hard, and what we found in buprenorphine, your first 3 patients are hard, and after 5 patients, you thought this is not so difficult. But to get over that initial hump, it takes mentorship. It takes someone to call. It takes someone who's a peer who's trying to get past similar administrative barriers or resistance or political or religious opposition. How do you manage and get through that? And so that's why we set up this fellowship program. So it's not just, here's a one-pager, make it work. It's you get regular meetings with people who are facing similar challenges about how do you get through your pharmacy formulary committee so you can get, you know, at least misoprostol, if not mifepristone, on your formulary. What's a grand rounds template so you can make the case to your peers about why this is evidence-based, even if you don't have OB-GYN backup in your hospital. And then change packages to help people with some of the hard work about changing hearts and minds that comes with whenever you try and adopt something new in a healthcare system.
So without further ado, we are so proud to unveil the new standard of care for treating pregnancy emergencies and providing access to contraception in the emergency setting. This is not intended to be a formal clinical training today. We are going to give an overview of what these algorithms are and how you might use them. And we welcome you to take these into the field. They're ready to go. Report back. How did it go? We'll talk a little bit more a little later in this webinar about how you can do that formally. But for now, these are ready to go. So Dr. Pfeiffer is going to walk us through our protocol on early pregnancy loss. And then Dr. Chotsky will talk about the algorithm to get patients contraception when they present in the ED.
And obviously this is so small, it's going to be hard for you to see. So this is available on our website, and that will be available in the link if you want to click on it and follow along. What we found with the addiction work is that some EDs who have champions can just take this and run, like use it, practice it, make it make sense, and then get started. Others benefit from the fellowship program that we have available. We will be doing intensive trainings on how to use these algorithms and webinars that will be available to everybody, even if you don't join the formal fellowship program. So what we're trying to do in this one pager is make it clear, how do you diagnose it, early pregnancy loss? So miscarriage can be fairly obvious. Someone who has a non-viable pregnancy who needs treatment is less obvious. So we have very detailed instructions about how you know something should be treated. And so you don't actually accidentally treat somebody who has a desired pregnancy that could be viable. Then we go through the 3 different pathways: the expectant management, which is pretty much status quo; medication management, which allows people to resolve their symptoms much more quickly and is very, very effective; and procedure management, including for emergency department clinicians who want to learn how to use a manual aspirator, which the team program that we're working with in Washington has excellent training on. And so if that's something that you want to do, you could also do the procedure as an emergency room clinician. It doesn't need to be an OB-GYN. And then we have an algorithm that uses mifepristone. While that is used for abortion, it's also very evidence-based to use it for miscarriage. And if mifepristone is not available, how to use misoprostol based on the stage of gestation. So if someone is miscarrying and has an empty uterus, you would treat them like in less than 9 weeks. If they have a pregnancy in the uterus by ultrasound that's 11 weeks, you would treat them in a different way. And then there's dosing if someone is in the 12 to 13 week range and you and the patient through shared decision-making are comfortable with medication management. And we also go through when you should consult an expert, what brief messages are really important to emphasize with the patient, and then what are the discharge instructions. So welcome feedback on this, where it's been tested in the field by Dr. Jagdeo, and we also want to hear from you how it works when you test it.
So this protocol is for patients who are presenting with a pregnancy emergency. But as we know, we see many patients presenting to the ED for all kinds of reasons who may lack access to the reproductive health care that they need. Dr. Chotsky, how does this algorithm help?
Thank you so much. This is some of the most rewarding and efficacious work that we can do as clinicians. So much like how we took buprenorphine as a medication technology and put it around a circle of care and love as clinicians and was able to transform how we treat addiction in the ERs as a quick start algorithm, this quick start contraception care can be some of the most life transformational things that we offer our patients. And it can take as little as 30 seconds to 5 minutes to do a really good start. And the idea here is that you as a ER doc, as somebody who's in that quick, fast-paced world, is getting somebody started on a good trajectory so that they can follow up and receive that full complement of care that we always want all our patients to have. So this is an algorithm that really starts with, we'll see later in this presentation, kind of how you frame the conversation and how you bridge that conversation. And the conversation starts with, would you like to have a pregnancy in the next year? And this is a super important question that gets left off of almost every single patient I see. So often I'm that first clinician asking them, maybe the first person in their lives asking them, do you want to have a baby this year? Do you not want to have a baby this year? And really supporting either decision that they make and really honoring that. So yeah, I do. Okay, well, let me make my mental model checklist. Did I just prescribe all the meds that are safe for a pregnancy? Can I get them prenatal? Can I get them hooked up with their primary care to make sure that they're living their best life for them and their future families? And then the other side of that answer is often no, or I'm not sure, or let me think about it. And how do we support somebody through that ambiguity? And also those patients who know they don't want to have a child in the next year and need our support. So the next step is, can I help you make a decision to prevent a pregnancy this year? Something to help them make shared decisions that are pretty quick. Now we all know, and we get the news, we see all these new birth control methods coming out, branded and unbranded, every day. And so we picked very effective, low cost, very widely available medications for people that they can start that day in the ER. And we provided patches, pills, rings, and depot shot options. So you don't have to memorize like 87 different options. You just kind of pick what's on your formulary. We help you, guide you through how to make that formulary work for your institution and your patients. And we help you do a quick risk assessment to make sure that those are safe for your patients that you're prescribing. And then we also talk about emergency contraception. So making sure everybody leaving the ER has things in hand to make their lives better. And that's really what our whole job is all about. And it's such an honor that we can do this and encourage people to do this as we go forward.
Thank you, Rebecca. We are really excited to hear how these go for you in the field. Rochelle, how has it been going? Rochelle has been using, before we let Rochelle talk about the pilot, I want to make sure everyone knows that if these algorithms are not enough for you, if you want to learn more, we have built an amazing partnership with a pioneering organization in this field, Training Education and Advocacy in Miscarriage Management. They are known as TEAM. You might have seen their big feature in NPR a little earlier this year about the innovative medical model they are pioneering. We are so lucky that they have shared their materials with us. So there are 2 longer versions of the EPL protocol. So if you do want to see a little bit more clinical explanation and citations about the early pregnancy loss information, they are there. And for providers who might want some materials about how to talk to patients about their options when they have experienced an early pregnancy loss, we have some documents that are both patient and provider facing that might help. So those are also on our website to be used alongside those protocols when you have a little bit more time. So Rochelle, how has this been going in the field?
Yeah, so at Marshall in Placerville, we launched this project, which was a great opportunity because for over a year, we haven't had a regular OB-GYN group. So we've had a need in the county. And in general, most emergency departments will defer the management of these conditions off to OB-GYN, which means that we probably haven't been trained appropriately because we've always been able to rely on somebody else. And when you don't have that backup, you kind of need some support. So the algorithms have really been able to empower us to have an amazing conversation with our patients to make a shared decision about what's going on. We have seen an increase in patient satisfaction as well as provider satisfaction with the use of the algorithms. Most ED providers want something that's really simple, easy to read, effective, and with a little bit of options and reference to side effects, risks, etc. So I think the algorithm has really been beneficial. And it's just easy to look at. I have it posted in the doc box and it's been working great. I have an example listed here, but I'll tell you an experience over the last couple of nights because I've been working nights. I've seen the same young lady for the last 2 days who presented with vaginal bleeding, which we had a great conversation. And I really loved the it's not your fault. I've said that multiple times to her. We talked about options. She wanted some more time. She followed up back in the emergency department because guess what? She had an appointment with OB and she got a phone call that her insurance was not valid and they weren't going to be able to see her. So guess what? She comes back to see me. We have the same conversation. Unfortunately, she's progressed and she naturally miscarried. But these are conditions that we treat every day. And why not be excellent at treating them? So it's really been really beneficial for us.
Thank you, Rochelle. I love that patient story, not because I love that that patient had nowhere else to go, but because I'm so glad that you were able to help her. So per Rochelle's story, this patient even had an appointment with OB, but wasn't able to get to it because she got denied by her insurance. We know that when patients present to the ED, they are often presenting with a lifetime of factors that got them there. Rebecca, what are some ways that we can be thinking about treating these patients from a trauma-informed perspective?
Exactly. So one of the, I would say, opportunities we have as clinicians is often our patients are telling us or telling our triage desk why they're coming. I sprained my ankle, I'm here for my suture removal or here for you to put in sutures. And it's up to us to really get to the place where we can change people's lives by providing them the care that they need and haven't been able to access. So there's a lot of bridging phrases that I've learned. And some of the ones that I particularly use every day is, Just because it's so hard to get in to see the doctor, I've started to ask all my patients about, and then ... about STDs or about contraception or about, your reproductive plan or, substance use disorder. So that's how I make the bridge from the presenting issue that they came for and the things I want to offer them so that they can live a long and healthy life. So that's how I bridge into contraception and birth control. And honestly, this is, as I was saying, a time when so many of my patients are like, I didn't know I could get that this year, or I didn't know I could get this at all. And I'm so glad you asked me. And it's, again, 5 to 10 second, making a comfortable transition. I also ask a question that's like, because it's so important to your health and I want to be an excellent care provider, I ask everyone, do you plan on having a pregnancy this year? And I say it to normalize this kind of conversation, but also because the legacy and stigma and bias of healthcare, as well as the world, means that often when you just ask that question, like, are you planning on having a baby this year? Like, it can be heard in a lot of different ways. And I say this from experience. I was a young, poor teen mom. And, so many people ask me, are you going to have another baby? At the end of every pregnancy, they were like, why aren't you doing contraception? But actually, as a healthcare provider now, I know that they were trying to do their jobs, right? But I heard it with the ears of somebody who is very fearful of seeking healthcare and very stigmatized in that healthcare setting. So had anybody just phrased it like, I ask everyone this, boo. Like, I ask every patient that I see today this question, not just you because I'm looking at you weird. I would have been able to hear it and accept those services much better. So speaking of being young, I obviously was a lot older than 12. But youth as old as 12 and older can consent to reproductive and healthcare services. And in the chat, we're going to drop that link to state-by-state examples of youth laws. And I really just want to say over and over again, the great thing about undoing stigma is it's something we can each individually do, and it's free as a part of our conversational skills that we get to improve every day. So there's systemic neglect, there's medical neglect, and the interpersonal skills that you will learn working with us and work with us to all of us learn better are the like icing on the cake so that we can do our jobs better and change the world as we go.
Thank you, Rebecca. And because we are the Bridge organization with our roots in substance use disorder, you cannot stop us from talking about drug use at least once. So how should we think about patients who present as pregnant and using drugs?
Thank you. I think of so much of this as a spectrum now. So we can see chief complaint, status post sexual assault on the tracking boards, right? We know there's some very specific and definitive examples of assault. I offer that many people live lives in our community facing choices that are very difficult. And sometimes they feel like choices that are thrust on people that aren't really choices. I'm talking about interpersonal relationships that aren't that safe. So we want to make sure that we're in a safe place that's confidential to talk to our patients and really understand where they're at. Simultaneously, we know that drug use is extremely stigmatized, especially around pregnancy and parenting in women. So we know that people who use drugs often are not offered great contraceptive and reproductive healthcare services. And if they are, they're often in the setting of some form of, if you don't do the thing that I think you should do, I might call some sort of hotline that's going to report you and your baby's going to be taken from you. Like, this is the community myth that unfortunately has very strong kernels of truth in it. So it's important to kind of think about the context of work that we do in a way that looks at that legal and structural legacy and how we as healthcare providers can have an interpersonal encounter with our patients in a great way that also changes the trajectory of how health and legal services are offered in our community so that, we're building health equity as opposed to worsening it. Just to think, birth control sabotage is very common. We've seen since the Dobbs decisions that calls to interpersonal violence hotlines have doubled. So these are issues that have always been present and are now really bubbling to the surface across the nation. So I want to encourage everybody to think about the intersectional reproductive healthcare and substance use population as we move forward. And we'll have lots of opportunities to talk about that in our fellowships.
Thank you, Dr. Trotsky. So that is everything that we've done so far. We learned about culture change in the ED setting. We talked to the pioneering experts in this space who came before us. we wrote these protocols and we tried to think about things through a lens of social justice and racial equity. I want to share a little bit about what's next, and then we want to hear feedback and questions from you. So short term, we are in the process of recruiting for a pilot of this work. We have a few champions confirmed, but we need more physicians to step up and say, I'd like to pilot this in my ED. I think the environment for it will be realistic, and I'm ready to work with your organization. So our goal right now is to finish recruiting for our fellowship that will launch in October. Beginning early next year, we will take feedback from that fellowship and refine these protocols. We anticipate making changes based on states that are not access states like California. And we hope that those protocols will be set to scale by mid next year. Just a little bit about that pilot. If your gears are spinning, if you might be interested, or if you might know a clinician who you could nominate, it is a funded fellowship. One value that we hold at the Bridge organization is to pay people for their work. So it is a $10,000 stipend for a 10-month fellowship that will require that fellow to meet with us monthly for both coaching and education about the protocols and culture change. And then you also will be giving us feedback that will drive Access Bridge version 2.0. So very excited to get this off the ground. It is well underway. If you or someone you know is interested, please get in touch with us after this webinar. And Rochelle, as you were a fellowship of one. You were the first person doing this work. Tell us what you hope will be the outcomes when we have more folks being funded to do this work.
Yes, so we're planning to expand into 5 communities that we've identified with access barriers in order to train ED providers and ultimately to make system change, to make a culture change so that we all are trained and comfortable in order to manage these patients' conditions. This is the ultimate goal of the fellowship, and we're looking for people that are really passionate about this, that would like to kind of join on the bandwagon. We want to make this the gold standard for ED care of reproductive health. And so we're excited to kind of bring on others and move the train along.
Thank you. And Dr. Pfeiffer, what's going to happen long-term and what do we need to make it happen?
Right, just echoing what Rochelle said, really encourage people to think about joining us, even if you're in a state that has severely restricted reproductive health care and you doubt that you will ever get mifepristone on your formulary, join us. We are really interested in working with the states that have been most affected by the changes over the last year. What we hope is that we continue to grow the emergency department as a true safety net where sexual and reproductive health care is offered with compassion and no longer stigmatized, just like we're seeing for addiction, where people used to be treated with a lot of stigma, and now we're seeing in emergency departments, people are welcomed, coming as they are, compassionately screened, treated, and then referred for ongoing care. So that's our goal, is that pregnancy emergencies, like any other emergency, you stabilize, treat, and then refer to specialty care if it's needed, but that for many, many people, they may be able to be completely treated in the ED, even if there's not specialty care available. And that the emergency department becomes one of many places where people can be routinely, compassionately screened and offered contraception if needed, because again, many people don't have other places to go. We are fundraising, so if you or your friends have deep pockets and want to contribute to the effort, please scan this here, do select Access Bridge. The more funds we can raise, the more emergency departments we can work with, and the more intensive way of doing the fellowship. We also, of course, hope that these algorithms are useful for many people who don't need the kind of high-touch support that is offered in the fellowship. So we hope you take these algorithms and run with them. Share this information if you know folks who want to support our efforts.
So we now will take questions. We have a few good questions that have come up during this presentation. So please contact us to learn more about the pilot or to speak with one of the experts on this call today. You can email me directly at this link, or you can use our contact form, which will also get to me directly. So I'm going to stop sharing my screen so this can feel a little bit more like a conversation. So both questions that I have so far are directed at Rochelle. So I'm going to start with you, Rochelle, and then we will we'll open it up. So if you want to ask questions, these can be clinical, these can be implementation in nature, these can be about our strategy. Just go ahead and drop those questions in the chat. So Rochelle, just to start with the nuts and bolts of this, what did you do at Marshall? Did you just start using the protocols one day? What permission did you need? Did you train anybody else? Are you the only one who knows how to do this now?
Yeah, so we met with our pharmacy group to ensure that we had everything on formulary, which we already had most of it. And then we also met with our OB group, and they were totally on board. We had very little hesitation. And I should preface this is that Marshall was one of the first for California Bridge to start buprenorphine. So the providers in general are very supportive and like getting involved. So I had absolutely no hesitation from my colleagues. I had sent out a training, and I have been working through with my colleagues when I'm on shift, getting everyone up to speed, answering questions. So, I mean, in general, it was a pretty smooth transition, no hesitation from anybody, and it has been well received. I think there was another question for me, right?
Yeah, so there's another question that I'll have you can begin answering, but I would also love to hear from Rebecca and Kelly about this. So the question is, one of the largest barriers that people have heard speaking to colleagues about this care from the ED is the fear of bad outcomes and subsequent litigation when it comes to pregnancy care from the ED. I definitely know this is what you read about in the news, right? Fear of providers not wanting to provide this care because they're worried about losing their licenses. They're worried about getting fines. So would you speak to how you overcame some of those barriers? Did you hear that at all? How'd you overcome that? And then Kelly and Rebecca, curious your input as well as to the mitigating risk piece of culture change.
Like Kelly had mentioned in the chat, there definitely is a change in litigation. We are talking about a relatively low risk population, and it doesn't carry the same litigation risk. If you refer to the protocols, anyone after basically 13 weeks or 14 weeks, you should get OB involved, and that may help offset litigation. Granted, I live in a state where I'm not having to call the C-suite or the hospital attorney when I'm managing a pregnant patient. So I'm sure people in other states may have different challenges, and that's the reason why we're kind of doing the pilot, so we can have experience in other states.
And if I could add, one of the things that the real advantages of working with the Public Health Institute, which is the umbrella for Bridge, is that you have rich resources in terms of thinking about legal barriers and legal questions. And most of the time we found that the barriers were perceived but not real. Like in buprenorphine, there was a sense that, well, is it really legal to give it from the ED? And we've heard, is it really legal to use Miffy and Miso in the ED? And it is. Also, a lot of the litigation in OB is later in pregnancy around labor and delivery. It's not management of early pregnancy emergencies, but certainly that's partly the benefit of the fellowship, is to surface these concerns, do the research, find out if they're real barriers or perceived barriers, and then you can solve them accordingly.
Dr. Chotsky?
Yeah, I would also like to say that we know intellectually that the biggest way to protect ourselves as clinicians is to build excellent relationships and share decisions with our patients and practice documenting and speaking in that mindful way more than any other policy or practice or anything else. Like good social skills with our patients is going to protect us. And that's what this fellowship does. It helps you build those skills so that you can just say the most elegant thing you can possibly say in the quickest amount of time possible, so that it just becomes second nature. So that's one of the benefits of this kind of program.
Yeah, and I'm very excited and a little bit overstimulated by my screens over here because I have several inquiries about the fellowship coming in while we're talking. So I want to address a couple of the questions that are coming in via the contact form. I just received a question that said, can you help navigate laws specific to my state when it comes to mifepristone use? So the answer to that is yes. We have a wonderful graduate fellow working with us who is on her way to law school, and as prepped for law school, she is going to be learning everything up, down, and sideways about the laws of every state where our fellowships are participating. So we do anticipate making either state-specific protocols or protocols that have an appendix related to your state in particular, and that is work that we are going to do for you in collaboration with anybody else we need to draw in to make that possible. So Kelly, is there anything else you wanted to add about state-specific support we're going to provide?
No, there's a robust network of pro bono attorneys that we work with in other areas. So we aren't going to leave you high and dry when it comes to these legal questions. We'll work with you state by state for sure.
Absolutely. And I also want to make a clarification about the fellowship, which is not just open to doctors. It is open to anybody who is a leader in your institution. So we are going to ask that at least one participating fellow is somebody who prescribes medication to patients. So that can be a nurse leader. It can also be an advanced practice clinician. So anybody who prescribes medication to patients is eligible for this. And if you have a buddy, so to speak, who is in leadership at the administrative level who wants to champion for this work, we will consider small teams for the fellowship as well. What other questions do people have? We are very excited to hear from you as this draws to a close, and very excited to get this fellowship off the ground. I got some good news about the paperwork end of the fellowship to make it as easy for everybody as possible. And we can't wait to hear how this goes for you all. Pause for another moment or so and see if there are any other questions from the group before we close today. Inbox is always open for inquiries after. All right, can a resident apply for the fellowship? That is a great question. Yes. I think yes. I think we would be supportive of a resident applying for this. Kelly, what do you think?
Yeah,
Yeah.
I think as long as you have leadership support in your emergency department. So the key thing is your resident can be a powerful change agent. Some of the best programs have come through because residents have time and passion, but you would need to show that you have support of your leadership, because being a resident without that support, it would be very difficult to make changes. So if you're interested, apply and we'll see what we can do.
Yep, we have learned a lot about the power of residents and the power of younger clinicians in general to activate change in some of these spaces that are more social justice oriented. So we love residents. And even if you are not a resident and apply, we would love for you to bring your residents to the fellowship, train them, make sure they know everything you know leaving their residency. So we are being asked, Rebecca, maybe this is a good one for you. Are there recommendations for navigating patient privacy, especially from parents?
Yes, we will be working on all of those issues, and also all the issues that you haven't even thought about. You know, one of the great things is that we'll be working together with a group of people who will be kind of road testing this program against so many different administrations and patient contexts, that you will have all the tools at the end of the year to be an excellent clinician in any setting.
Yeah, and we do have one of the supporting materials posted on our website is a consent form for this care from the team, our team friends. So you might go to the resource page or go to the Access Bridge website and click on that resource to see what we already have vetted to offer. Other
Another
questions?
side of privacy, if I could just bring up, is Dr. Lauren Mans-James, who's on this call, who's a nurse leader, wrote a really interesting article about patient privacy when they're coming in with self-managed abortion, and what you need to document in the chart and what you shouldn't document in the chart. So I'm wondering, Laura, if you would mind putting that in the chat so that people have access to that article, because as you know, with health information exchange, if you put in the chart that someone came in after self-managing an abortion, which means ordering pills online to do at home, and they come in with bleeding, and that they are living in a state that criminalizes abortion, that could create a lot of problems. So the article goes through what your ethical obligations are around documentation, and that you actually do not need to document in the chart that a patient took pills to cause a miscarriage. You can document that they presented with the signs and symptoms of miscarriage, because the treatment of bleeding after a medication abortion is no different than the treatment of bleeding from miscarriage that's not induced by pills. So in any case, the article is there if you want to read it, but it does address some of the more challenging privacy issues that have come up since the Dobbs decision.
I am very interested in and fascinated by these questions of how to code for pregnancy emergencies in a way that protects patients in states where they may be at risk. So we will definitely be considering what we need to provide people going forward in that space. That's a great question. Thank you, Laura, for that article. We can maybe share that out in the post-event email as well. Thank you. Other questions? All right. Well, inbox is open. The fellowship application is going to be available probably early next week. And then we intend to confirm the list of fellows very early September. So right after Labor Day, we anticipate having that group together. So thank you for your interest. Thank you for taking the time to attend live today. You will receive the recording a little bit later today. Please forward the recording to anybody who you might think is interested in the future of reproductive health care in America. And thank you to my co-presenters today. Thank you, as always, to the communications team at the Bridge organization for making us look as professional as possible. And I hope everyone has a really wonderful rest of your day, and we look forward to working with you soon.